اللهم صل وسلم على محمد وعلى آله وصحبه وسلم. Diabetes emergency. Diabetes emergency from the Ministry of Health Pocket Manual in Emergency, Saudi Arabia Ministry of Health. So, diabetic ketoacidosis, hyperglycemic hyperosmolar syndrome. These tables differentiate between DKA and hyperglycemic hyperosmolar syndrome. In the diabetic ketoacidosis is profound. The glucose is around 250 to 600 milligrams per deciliter. The HCO3 is less than 15. The osmolarity is between 300 to 325. Age of patient young. The onset acute over hours to day. The associated disease is common. Seizure is very rare. Coma is rare. Insulin level very low to none. Mortality between 0 to 10% depends on underlying condition. The dehydration is severe. Hydration is severe. This is diabetic ketoacidosis. The hyperosmolar, hyperglycemic hyperosmolar syndrome, the ketoacidosis is minimal or none. The glucose often more than 900. The HCO3 is more than 15. Osmolarity often more than 350. The age of patient elderly. The onset chronic over days to the 2 weeks. Associated disease also common. Seizure is common. Coma is common. The insulin level may be normal. Mortality between 20 to 40%. The dehydration is profound. So there are some difference between diabetic ketoacidosis and hyperglycemic hyperosmolar syndrome. Ketoacidosis in DKA profound, but here minimal or none. Glucose in DKA is around 250 to 600, but in hyperglycemic is more than 900. The HCO3 in DKA is less than 15, but in hyperglycemic more than 15. The osmolarity in DKA between 300 to 325, but in hyperglycemic is more than 350. The age in DKA usually young, but in hyperglycemic elderly. The onset in DKA acute over hours to day, but in hyperglycemic is chronic over days to weeks. The associated diseases are common in both. The seizure is common in hyperglycemic, the coma common in hyperglycemic, the insulin level normal in hyperglycemic but very low or none in DKA. Mortality in DKA from 0% to 10%, and in hyperglycemic from 20% to 40%. Dehydration is severe in DKA. In hyperglycemic, hyperosmolar syndrome is profound. So the clinical presentation, history, polyuria, polydipsia, polyphagia, polyuria, polydipsia, polyphagia, weight loss, fatigue and weakness, abdominal pain, nausea and vomiting, hyperventilation, altered mental status, and about the associated infection, another associated illnesses, the medication, and so on. So the history: polyuria, polydipsia, polyphagia, weight loss, fatigue and weakness, abdominal pain, nausea and vomiting, hyperventilation, altered mental status, history of infection or associated infection, associated illnesses, history of medication. The physical examination, mucous membrane dry, skin temperature decrease, sunken eye, tachycardia and hypotension, the pulse may be weak and 3D, abdominal pain or tenderness, nausea and vomiting, lack of bowel sound and eye loss, compensatory hyperventilation from the metabolic acidosis, sarcasmal respiration, altered mental status, febrile. Root debris and DKA. The workup: complete blood counts, full chemistry, VBGs, serum glucose, serum ketones, serum osmolarity, urine analysis and culture, lumbar puncture if clinically indicated, hemoglobin A1C demonstration, and the management. Pre-hospital care, primarily supportive. Providers should have access to blood glucose measurement device. Intravenous line should be started and normal saline giving as a bolus of up to 1 liter in the average sized adult. Medication should be identified and brought to the emergency department. Identification of precipitating or comorbid illnesses. High incidence of infection in HHS patients had led to recommendation for early empiric antibiotic therapy, even no source is identified. DKA. Fluids. Hypotensive. If the patient is hypotensive, administer a bolus of 1 to 2 liters of normal saline, 0.9% over the first hour. The pediatric dose is 20 to 40 ml per kg. If hypotension persists, then give another bolus. If the patient is normotensive, then use 0.9% saline at 1000 cc per hour. The patient has renal failure or has history of congestive heart failure, then invasive monitoring with central venous pressure monitor. The insulin. Intravenous insulin administration regimen is continuous infusion of 0.1 units per kilogram per hour after you have potassium level. Intravenous insulin administration regimen is continuous infusion of 0.1 units per kilogram per hour after you have potassium level. Bicarbonate. The use of bicarbonate is not recommended for DKA. The potassium more than 5.5, hold potassium, check potassium every 2 hours. Potassium from 3 to 5.5, give 20 to 30 millimole to keep serum potassium at about 4 to 5. If potassium is less than 3.3, hold insulin, give potassium 40 milliequivalent in adults per hour until potassium is more than 3.3. and carefully monitoring the glucose every 1 to 2 hours by finger stick, confirmed by lab correction when indicated. The basic metabolic profile for anion gap and serum potassium at the onset of treatment, at 1 and 2 hours after the onset of treatment, and at 2 to 4 hour interval until patient is substantially better. Arterial or venous pH follow as indicated to monitor clinical status. Insulin dose and routine administration every hour. IV fluid every hour. Urine output every hour. Disposition. Disposition admitted the patient to ICU. Hemodynamic instability, unable to define the airway. This patient should be intubated. Obtunded. This patient should also be intubated. Abdominal distension. Acute abdominal signs or symptoms suggestive of acute gastric dilatation are present. Surgical consultation should be considered for this patient. Insulin infusion cannot be administered on the ward. Monitoring cannot be provided in the ward. Comorbid disease such as sepsis, myocardial infarction, or trauma. And thank you.